All right. In the interest of time, we're going to go ahead and get started. So welcome to everyone. It is my pleasure to introduce Dr. Bri Wilkie this afternoon. So a little bit of a history lesson regarding Bri. So my first interaction with Bri really occurred last summer when the Division of Medical Oncology was trying to recruit her away from University of Miami. Now, I recall the more than 1 hour meeting that we had discussing her projects, discussing her translational research program initiatives, and probably most of the time the discussion was focused on trying to understand why you were trying to leave the paradise that we all know as Miami. So it was a really insightful conversation, and what was obvious from that conversation to me, and it's still really deep in my mind right now, is her passion and her excitement for immunotherapy, her excitement for conducting research, her excitement for establishing collaborations and moving things forward clinically. So by the end of that telephone call, I knew we had to recruit Bri, and I also knew from that moment, from that brief conversation, that her coming here was going to be tremendously impactful to the university and to our community. So with regards to Bri's education and training, she received her medical degree from the Robert Wood Johnson Medical School, now known as Rutgers Medical School in New Jersey. She went on to conduct her residency and fellowship at Johns Hopkins, where she eventually was a chief fellow there for a couple of years. Shortly after that, she received her first clinical and faculty appointment as assistant professor in the Department of Medicine, the University of Miami Sylvester Comprehensive Cancer Center. She served as the co-director of the Phase 1 clinical program there. She was at Miami from 2013 to 2018. The last few years, she really honed her skill on leading Phase 1 clinical programs. Bri is a relatively new faculty on campus, having just arrived in November or October of last year. And I have to admit that her career is off to a really great start. She serves as PI on 6 grants. One of these grants is the highly prestigious and highly competitive American Cancer Society Mentored Research Scholar Grant, and it's focused on enhancing efficacy of checkpoint inhibitors with VEGF blockade. Despite the fact that she's been here less than a year, she's been able to secure a grant from the Cancer League of Colorado. This is a Phase 2 trial of doxorubicin in combination with dual checkpoint blockade in sarcoma. And she has several other industry-sponsored Phase 1 clinical trials in which she serves as PI, all of them really geared towards understanding how to reactivate anti-tumor T-cell responses. She's also had a really nice steady stream of publications. One of her most recent publications this last June was published in the high-impact journal Lancet Oncology, and it was really focused on assessing the efficacy of axitinib plus pembro in sarcoma patients. So, I'll kind of end this by reiterating what I mentioned previously, that is Bri's presence here is going to be highly impactful. Bri, we're so happy you decided to join us. I know you had a lot of great choices. We're incredibly excited and happy to have you. So if you all will welcome Bri to the stage, appreciate it. Thank you, Bri.
Okay, that is the best introduction I have ever had. So thank you, Eduardo, so much for your kind words, and I am delighted to be here at the University of Colorado with all of you. It's been incredibly exciting so far, and I know that the best is yet to come. So over the next few minutes, what I'm going to do is walk you through why I think we should be trying to harness the immune system to fight sarcomas, which are rare cancers of bone and soft tissue. And so we're going to go on a journey together. We're going to start at the clinic, looking at some of the clinical trials that have been done. We'll go back to the bench and the mouse room, and then hopefully we'll be able to put together some new ideas in order to improve the next generation of clinical trials for patients with these diseases. So I have a few disclosures. So I thought I would start with 2 patient stories, and the reason is that, number one, all amazing ideas come from patients, but the other reason is that these 2 patients, for me, were really the trigger that made me want to focus on immunotherapy because of the amazing responses that you can see, but also made me understand how far we had to go in order to make this work for all patients. And so the first patient, his name was Manny Alvarez. And so he walked into my clinic in Miami about a year after I'd come there. And he was a 22-year-old college student and spear fisherman, as you can see. And he had just been diagnosed with a disease called alveolar soft part sarcoma. So this is an incredibly rare subtype of sarcoma, less than 100 cases per year. And unfortunately, the majority of these are metastatic at diagnosis, and historically, at least, they are universally fatal. Chemotherapy or traditional regimens do not work. The only thing that seemed to help is VEGF blockade or angiogenic directed drugs, but even these are just palliative. And so Manny's family was understandably distressed, and they started a foundation to raise awareness because there was only one clinical trial and essentially zero laboratory research going on for this subtype at the time that I met him. And so one of my colleagues at Miami happened to have run a study of GVAX for ASPS patients during his fellowship. And in the course of that study, they noted that PD-1 was expressed in some of these tumors, and importantly, that they developed antibodies to angiogenic factors after treatment, suggesting a link between angiogenesis and the immune system. And so we proposed a study of axitinib, a VEGF inhibitor, with pembrolizumab for patients with sarcoma, including ASPS. And so it took a while to open the study, but we were able to get Manny about 6 weeks of treatment on that study before he died. But what led to afterwards is actually that over 50% of the patients with ASPS who came after him achieved durable and meaningful responses. The other patient is a 63-year-old female. She has a disease, sorry for the picture, she has angiosarcoma of her nose and cheeks. So this is a very infiltrative, aggressive blood vessel cancer. And it's weird because it's all localized. It doesn't spread, it doesn't metastasize, but clearly it's quite disfiguring and devastating. And so I had met her very early on, and we had gone through a host of different treatments, including cytotoxic chemotherapies, radiation, and even a rhinectomy, removing her nose in an effort to salvage her, and nothing was working. And so the week that Manny died, I actually enrolled her on a phase 1 trial of a novel CTLA-4 antibody called AGEN 1884. And she was the very first patient in this old school phase 1 study. And so dose finding, she was treated at 0.1 mg per kg, which is 10 to 30-fold less than the equivalent doses of ipilimumab. And so within 12 days, we saw this robust inflammatory response in her tumor here. And she went on to achieve a complete response radiographically by March of 2017, about 6 months later. And then we confirmed a year later that pathology-wise, she had absolutely no residual disease as well. And so we've gone on after this super responder to treat a variety of patients with cutaneous angio with checkpoint inhibitors and have seen some pretty remarkable responses as well. And so I'm not alone in my obsession with immunotherapy, I'm sure. And obviously, you all know that there are a host of different ways that immunotherapy is being explored in cancer care, and that it's clearly become one of the modern pillars. And so today I'm going to primarily focus on checkpoint inhibitors and combinations. You could do a whole other series of talks on adoptive cellular therapy, but for today we will focus primarily on checkpoint inhibition. So also, as you know, in order to get an effective anti-tumor immune response, there are multiple steps that have to happen. So first and foremost, you have to have a supply of tumor-specific antigens that can be recognized and presented by your antigen-presenting cells, known as tumor immunogenicity. Then those antigen-presenting cells must go on to activate and generate a tumor-specific T-cell population. If you don't have T-cells, all of your efforts further downstream are really pretty moot. Once you have your tumor-specific T-cell population, it then has to be able to traffic, migrate, and infiltrate into the tumor bed. And then lastly, there has to be recognition of a threat at that tumor T-cell interface. And so as you know, cancer cells have derived a variety of evasion mechanisms to avoid detection at all of these different steps. Many cancers have low mutational burden, so they start out with few neoantigens. They can lose expression of MHC class 1 or have other failure in the innate immunity side of things, leading to poor antigen presentation. There are a variety of suppressive immune cells, tumor-associated macrophages, T regulatory cells that further suppress the T cell's activity and ability to infiltrate, as well as suppressive cytokines. And then, as we all know, tumor cells can directly express checkpoint proteins, including PD-1, PD-L1, and CTLA-4, that can all lead to suppression of the tumor T-cell cytotoxic attack. And so, as we know now, modern immunotherapy is aiming to target cancer at all of these different mechanisms. And so there's a large variety of different ways that you can do this, But really all of this kicked off most recently with the development of checkpoint inhibitors. And so really these have been the backbone of our efforts in modern immunotherapy. And so this is a very small table, which is already outdated despite having been approved as March of 2019, but it's just showing you that antibodies to CTLA-4 and PD-1 have dramatically impacted the approvals and the cancer treatment paradigms for a large variety of solid tumors. And so most recently as well, we've seen approvals for combinations, targeted therapies such as VEGF inhibitors with checkpoint inhibitors for renal cell carcinoma, and chemotherapy in combination for lung and breast cancers. And in fact, this crazy bubble plot is illustrating all of the different types of combination trials that are currently ongoing for solid tumors. And it's truly amazing how much effort is being put into finding ways to improve the outcomes of these incredibly powerful drugs. Notably, sarcoma is not on any of those lists. And so let's take a step back and let's talk about sarcomas. So as I mentioned, sarcomas are very rare. They are actually over 100 to 150 different types of bone and soft tissue cancers. And these are what we call mesenchymal neoplasms. So basically, you have progenitors that give rise to soft tissue and bone components, such as fat cells, soft tissue cells like fibroblasts, muscle, and so on. And if you get a malignancy in any of those progenitor cells, you technically can develop a sarcoma. And so they're classified by basically their cell of origin, what they were supposed to become had they not developed that mutation. About 80% of sarcomas will be in soft tissue, 20% in bone, and collectively all of these together make up only about 1% of adult cancers and 15% of pediatrics. So despite having a relatively low number of new cases per year, they have a high mortality to incidence ratio. There's a lot of deaths despite their rarity. And part of the problem is that these tumors are incredibly heterogeneous. So there are sarcomas that are genetically driven by conserved translocations, particularly pediatric sarcomas. Some sarcomas have very defined driver mutations, like c-KIT mutations in gastrointestinal stromal tumors. But most of the sarcomas we see in the adult clinic, the more common ones and the more aggressive ones, unfortunately have very complex genetics, many copy number abnormalities, karyotype disruptions, and if they do have mutations, they tend to be in the undruggable tumor suppressors like P53, RB1, and ATRX. And overall, with rare exceptions, most sarcomas are going to have very low mutational burden. So our standard treatment, of course, is cytotoxic chemotherapy. That's what we've been doing for many years. And unfortunately, it's still not particularly effective. So the 5-year survival for most sarcomas is less than 20% in the metastatic setting with these chemotherapies. Now, we have made some progress with certain histologies, particularly the pediatric subtypes, where we can get cures in these patients with multi-drug regimens. But most, again, of the sarcomas that I see in my clinic, the common adult types, you can palliate with chemotherapy, but it's extremely rare to cure anyone in the metastatic setting with these types of drugs. Further complicating things is there's a significant number of sarcoma subtypes that are completely resistant to cytotoxic chemotherapy, and so targeted therapies have made some progress, but again, these are really incredibly challenging. And so for the patients getting treated with chemotherapy, our standard of care is still single-agent doxorubicin, and this has been the case since the 1970s. And despite numerous clinical trials attempting to improve outcomes over single-agent doxorubicin, we have failed to find any drug or combination that improved overall survival over monotherapy. And again, response rate remains less than 20%. Progression-free survival remains modest, somewhere around 6 months. And so one thing I will say, though, even with these dismal statistics, there are still a few patients that have remarkable outcomes, probably somewhere between 3 to 5%. And what I mean is that these patients, if you could take them to surgery and resect all of the metastatic disease, they can go on to live years, which is surprising. Additionally, there are some patients that can live with metastatic disease, visible metastatic disease, for years, 5 to 10 or even more years. And so we don't completely understand why that is. They just have a very indolent course. But it's tempting to speculate that maybe the immune system is playing a role in suppression, because certainly our chemotherapy drugs are not good enough to kill all of these micrometastatic sarcoma cells. And so novel therapies are clearly needed, but we have challenges when we're trying to develop drugs for rare diseases, and this is regardless of whether you're looking at chemotherapy, targeted therapy, or immunotherapy. Because of the rarity, most of our large sarcoma trials bring in multiple subtypes. And so I've already shown you how different all of these different cancers are. And so that dilutes signals of activity. So we've been trying over time to cluster our efforts towards subtype-specific studies, but that requires multiple institutions to work together, cooperative groups, and you have to get pharma to really buy in for a very, very small population, which is often not in their priorities. The heterogeneity we mentioned, patients are different within histologies, and then there's tremendous intrapatient and intratumor heterogeneity. These tumors tend to be large, and so regional differences in tumor biology are very common. As I mentioned, limited interest, funding, and awareness by industry and NCI, and so we can't do those robust correlative studies that we need to tease out signals in large trials. And then finally, there's limited preclinical models, and so the ones that we have often don't capture the clinical heterogeneity, and so we wind up failing when we get to clinic, even with promising murine data or cell line data. So let's turn now to immunotherapy. And so I will lay claim that the actual tumor that William Coley first treated back in the 1890s with his streptococcal toxins was in fact a sarcoma that regressed. That being said, that didn't go very well for very long. And so immunotherapy fell out of favor for quite some time as a result. But in the 80s and into the early 2000s, people were trying to use cytokine therapy along with chemotherapy, particularly for osteosarcoma. And there's this drug called mefamortide, which actually did improve outcomes to some degree and is approved in Europe for osteosarcoma, but we don't use it here because of various political controversies. Vaccine therapy was explored pretty heavily in the late 2000s, and unfortunately it was pretty disappointing for most sarcomas, again, probably because of all of the suppressive mechanisms that we're now more familiar with. In 2010, Steven Rosenberg reported some of his first studies with adoptive cellular therapy for NY-ESO1 positive synovial sarcomas. And this is an effort that's continuing to move forward today. We're still targeting NY-ESO1 as well as other targets like MAGE-A4. Checkpoint inhibitors, the monotherapy studies began in 2013 or so, and now we're in the age of combinations and looking back, trying to figure out some of the microenvironment considerations. And so where I think we're headed, and what I hope to convince you by the end of this talk, is that our next steps are really developing predictive biomarkers across our sarcoma subtypes to guide precision immunology. So now I'm going to walk you through the studies that have been done so far for immunotherapy with checkpoint inhibitors in sarcomas. So the first study was SARC-028, pembrolizumab monotherapy, so 200 milligrams every 3 weeks. And so there were two arms to this study. The first arm included soft tissue sarcomas, so leiomyosarcoma, UPS, liposarcoma, and synovial sarcomas. And there were only 40 patients, 10 per subtype. As I'll show you, based on initial responses, they did actually expand this study with an additional 30 patients for UPS and liposarcomas. The second arm of the study was bone sarcomas, chondro, Ewing sarcoma, and osteosarcoma. And again, 40 patients here, not restricted by subtype. They did obtain correlative blood and tumor biopsies at baseline, on treatment, and then optionally at progression. And the primary endpoint for the study was response rate. And so these are the waterfall plots for the two arms. So on the left, we have the bone sarcoma waterfall plot, which unfortunately was pretty disappointing. Only 2 responders out of 40. One patient with chondro and one with osteosarcomas. And the median progression-free survival was only 8 weeks. Also frightening is the rate of hyperprogression, or these patients had tumor increases of over 500% in some cases, and so this was really surprising and disappointing finding. On the soft tissue side, things were a little bit better. So the response rate was 18% with a median progression-free survival of 18 weeks. And we saw out of the 10 patients with UPS, 4 responders, 1 complete responder, and 3 partial responders. We also saw 2 of the 10 patients with liposarcoma achieving partial response. And so based on these outcomes, this is why they added the additional expansion cohorts. There were no responses in synovial and none in leiomyosarcomas. And unfortunately, when we added more patients, we found out that actually the responses were not that great either. It was down to 23% for UPS when you put all the patients together and 10% for liposarcomas. Now, they did do some correlative work with this study. However, if you look at the number of patients and the number of samples and the number of people who had benefit, it's very difficult to do these correlates. So this is sort of the first example of how challenging figuring all of this out can be. So what I will point out, though, is that they looked at baseline tumor PD-L1 expression, and out of 70 biopsies, PD-L1 was only positive in 3, and all of those cases were UPS. Now, only 2 of those cases actually had response data, but 1 patient did have a CR and 1 had a partial response. There were still 6 responses in PD-L1 negative patients, however. And so the point of this is that PD-L1 is not required for response, and it's not sufficient to determine likelihood of response either. They also showed that in patients that had a better response, so CR or PR, there tended to be increased immune infiltration with type M1 macrophages, cytotoxic T cell infiltration, effector memory cells, and Tregs. And so again, kind of pointing towards this more immune infiltrated or hot tumor paradigm. Also, they noted a few soluble cytokines that were associated with improved PFS. And so these data will come out in a manuscript hopefully soon. So the next study combined ipilimumab and nivolumab for sarcomas, and so this was the Alliance trial. So 95 patients were randomized 1-to-1 to either ipi-nivo or nivolumab monotherapy, and they were allowed to cross over to the ipi-containing combination if they progressed on nivo monotherapy. The primary endpoint of this study was response rate, and again, they obtained biopsies at baseline and on treatment at week 6, as well as blood samples throughout the treatment. And so just looking here, there were 85 patients that were enrolled on treatment, and you can see again a wide variety of different sarcoma subtypes. Importantly, they only included 5 patients with liposarcoma and 11 with UPS. So remember, these are our 2 histologies that after SARC 028, the community is thinking, oh, well, these are the responders. These are the ones that we should be treating. And so here's the outcomes from this study. So nivolumab monotherapy, again, across all comers, response rate of 5%, with a response in ASPS, or alveolar soft part, leiomyosarcoma, which we hadn't seen any responses before, and sarcoma not otherwise specified, which was an unconfirmed. But overall, the median progression-free survival was pretty dismal at 1.7 months. In the combination arm, the response rate was slightly better, 16%, and again, we see responses in leiomyosarcomas and angiosarcoma, myxofibro, and a UPS, with a median progression-free survival of 4 months, 4.1. No responses in liposarcomas, although a small number of patients, and again, only 1 out of 11 patients with UPS responded. We are still waiting on correlative data from this study. The third study is a study called Pemrose Sark. So this study combined pembrolizumab with metronomic Cytoxan. So Cytoxan is well known to selectively deplete T regulatory cells, and Tregs are implicated in resistance to immune checkpoint blockade because of their suppressive effects on antigen presentation as well as T cell activation. And so the endpoints of this study was a 6-month response rate, and they enrolled 15 patients with leiomyo, 16 with UPS, and then a smattering of other histologies, including GIST. And the results here are even more dismal. So absolutely no responders. No one met the 6-month progression-free rate with GIST. The only responder was in a tumor called solitary fibrous tumor, which was PD-L1 positive with a robust T cell infiltrate. So at least that made sense. But why this didn't work for UPS or leiomyosarcomas or liposarcomas was pretty concerning. And so they also did some correlative studies. Surprisingly, they didn't look at Treg analysis, which is what they set out with their hypothesis of the study. But they did look at PD-L1 expression in tumor and immune cells with inpatient tumors. And again, you see that only 1 patient had super high PD-L1 expression. And with only 1 responder, it was clear that PD-L1 expression in tumor or in immune cells are not predictive of response. And then the other thing they looked at is correlations with the M2 macrophage infiltration. So M2 macrophages are the more suppressive phenotypes. And what they were able to show is a relatively high infiltration rate across these different cohorts. So basically 1-to-1 between M2 and M1 macrophages. And in UPS, 73% of the samples were above the median for the entire cohort. And so their argument is that potentially this M2 macrophage infiltration could potentially explain why this combination was not particularly effective. And so something to consider moving forward. So the next study is axitinib plus pembrolizumab. So this was the study we mentioned at the beginning. And so the rationale for this study is, again, that vascular growth factor is really this master cytokine that has many different previously confirmed mechanisms for suppressing the immune microenvironment through a variety of mediators. And so concurrent blockade with VEGF therapy along with immune checkpoint inhibitors has been shown to improve T-cell infiltration and activation in renal cell carcinoma and melanoma. On the sarcoma side, high VEGF expression and hypoxia have been associated previously with poor prognosis and resistance to chemotherapy. And we have been able to get some benefit, mostly palliative, but at least some stabilization of disease using VEGF receptor tyrosine kinase inhibitors like pazopanib. And then, as I mentioned, ASPS has a fusion protein, and their downstream transcription targets include angiogenic factors. And so we think that's why many of TKIs are active in this disease, and that's part of the reason why we wanted to include it in this study. So this was a single-arm phase 2 trial of 30 patients with advanced sarcomas. The primary endpoint was the progression-free survival rate at 12 weeks, with a historical benchmark for activity in this population of about 40%. And then secondary endpoints included response rate, toxicity, and so on. So our patients received a week of axitinib, the VEGF inhibitor, to prime them before beginning pembrolizumab every 3 weeks. And we obtained tumor biopsies and blood sampling at baseline, on treatment at the 3-month time point, and then at progression. So here are the outcomes from this study. So in the waterfall plot here, you can see the responses. Overall, our 3-month PFS rate for all patients was 65.6%, and ASPS was slightly higher at 72.7%. We did actually enroll 12 patients with ASPS on the study, which we were very surprised about simply because they are so rare, but we had patients coming from all over the country and internationally to go on this study. Fortunately, we did see that 6 out of the 11 evaluable ASPS patients responded, and the median duration of response was 29 weeks, so about a 54% response rate. Unfortunately, in the non-ASPS patients, we only saw 2 out of 21 responses, so less than 10%. Similarly, the progression-free survival for non-ASPS was about 3 months. We did see partial responses in epithelioid sarcoma, which is a terribly nasty sarcoma resistant to chemotherapy. And then we were happy to see some evidence of benefit in soft tissue leiomyosarcomas, but again, very low numbers of patients here. We did not see any responses in UPS or liposarcoma either. And so we'll talk about the correlatives for this study for axi-pembro here in a few minutes. Last trial, I promise. This study, it combined pembrolizumab with doxorubicin, traditional chemotherapy for sarcomas, and this was just presented at ASCO this year. So doxorubicin is well described in the preclinical literature to boost tumor immunogenicity, okay? And so this induces expression of those danger signals associated with immunogenic cell death, has some effects against M2 macrophages, which should be helpful considering what we saw in the other study, can help induce tumor production of type 1 interferons, leading to improved T-cell production and infiltration in tumors. And so Seth Pollack out of Seattle ran this study. It was a phase 1, phase 2, with the primary endpoint, at least in the phase 2 portion, of objective response rate. And so these patients were primed with 1 cycle of pembrolizumab, followed by doxorubicin for 6 cycles, and then pembrolizumab maintenance therapy afterwards. And so again here, what do we see? We see a 22% response rate. There were 9 partial responders on this study. Again, and some patients had benefit in leiomyosarcoma, liposarcoma, and UPS with this regimen. There also were a significant number of patients with stable disease, so the clinical benefit rate or stabilization of disease was up to 80%. However, this study was negative because the primary endpoint was response rate. And so the other interesting thing that they saw in this study was that the median progression-free survival for patients was high. It was at 7.8 months. And if you compare this to other studies in the past with doxorubicin monotherapy, this looks better. But the other problem is that we're getting better at our supportive care, and so the progression-free survival and overall survival has increased as we've gone along just because of that. And so overall, this is still a question that's up for further debate, but this will likely move to a randomized study at some point in the future. So why did I just drag you through 5 trials for sarcoma when I could have just showed you this picture? So I'm trying to emphasize a repeating theme. So we have now conducted at least one study, a small study, but at most of these major resistance mechanisms that I showed you to begin with, and it's not working. We're still seeing a subset of patients with exceptional benefit, but overall, the majority of patients are not having responses. And so how do we need to move forward? How can we improve our chances of understanding what's actually happening and tailoring immunotherapy for more patients? So with the clinical background, let's go to the bench and let's start to look at what we're seeing here. So with the advent of checkpoint inhibitors, there have been multiple retrospective studies that have gone back and looked at the immune microenvironment, and much of this we mentioned and we see confirmed in the clinical studies, but low tumor mutational burden for most sarcomas, up to 60% of sarcomas have been reported to have lost or downregulated MHC class 1. Macrophages and myeloid cells predominate over exhausted T cells or Tregs inside the tumors for most cases. And again, low rates of tumor PD-L1 expression across the board. But what's also interesting is that in the last couple of years, there have been 3 studies going back and looking at genetic expression analysis of archival sarcoma subtypes and looking at immune signatures, so clusters of genetic pathways associated with immune activity. And most of these subtypes have included the big 4 that we've been talking about most of my presentation already today. But what they're showing in general is that there are clusters. There are clusters within each histologic subtype of low, intermediate, and high underlying immune activity, which is exactly what you would expect looking at the clinical outcomes. So looking at this in more detail, this is one of these studies. This is the TCGA paper published in Cell in 2017, where they went back to 200 soft tissue sarcoma samples and performed profiling and looking in part at the immune signatures across these different tumors. And so you can see here in this subset of a figure here, macrophages, CD8 activity. It's not so much important to look and say, well, liposarcoma is higher than UPS for the median, and synovial is just low. What I want you to take away from all of this is look at the ranges. So if this is the immune infiltration score, the relative mRNA level, there is a huge range across these histologies, and it's not like there's just a couple outliers here or there. It's really a diverse range across each of these subsets. Similarly, looking more broadly at a variety of immune signatures in this study, again, you see a mixture of histologies represented here across the board. The histologies don't cluster that closely, but there is this cluster of high immune-related activity across all of these different signatures. And again, different histologies are represented here. Also importantly, what they showed is that these immune clusters tend to associate with improved disease-specific survival. And so again, supporting that having an immune system that's functional may lead to better outcomes. The other more recent study that's been presented looked back at multiple genetic transcriptomic subsets that are out in the literature, and about 700 sarcomas were represented in this study. Again, primarily UPS, leiomyosarcoma, and liposarcomas. And using a deconvolution method, they were able to derive 5 clusters, 5 different subsets of sarcomas from cold to hot, basically looking at the tumor microenvironment composition, functional orientation, including major histocompatibility complex 1, and checkpoint protein expression. And what I'll point out here are a couple of things. So the highest immune subsets actually had tertiary lymphoid structures within the tumors. So these little mini lymph nodes, basically incredibly hot spot for immune activity. The other thing is that they showed is that, again, these immune subsets correlated with overall survival. The more immune activity you had, the better you did across all of the data sets. And then they also looked at the patients treated with PD-1 and Cytoxan in the Pemrose Sark study that I showed you. And although this had nothing to do with response, the patients with the high immune scores still did better in terms of overall survival. One other thing I'll point out, again, we're seeing these histologies represented across all 5 subsets. So it's not like all of the UPS is clustered at the hot side, which is what we initially were hoping looking at some of the clinical data. There's a range, and this fits with everything that we're seeing. So putting the clinical data together, these clustering analyses together, this is what I want to propose. So regardless of what biomarker you're looking at, whether you look at PD-L1 expression or macrophages, or you look at clinical outcomes, progression-free survival, response rate, this is what our trials look like in sarcoma. There's a huge range, and historically we've combined a whole bunch of different histologies. And so our method to designing trials for sarcoma, we've been pushing more towards histology as the stratifier, basically looking something like this. But for immune responses, we're going to be forever stuck at that 20% ballpark unless we change our paradigm. And so this is the paradigm I think we should do. We should look at how to isolate out the high expressors of whatever you're looking at, the intermediate, and the low. And this is how we need to design our trials, because this will not only help cut down on some of the heterogeneity and improve the responses, you're actually going to have multiple subtypes, which will improve your ability to accrue to clinical trials. So how do we get there? How do we develop those biomarkers? How do we figure out what's most important across all of these random trials, these small numbers? What do we do? Well, I told you already, there's no way that sarcomas are going to be able to participate in all of these different shotgun combination studies, nor should we. And so I think the answer really comes from this tweet from a couple days ago from James Allison. And so he was lecturing, and he too was disappointed by the lack of correlative follow-up work with all of these combinations. And the quote is, "If you don't learn something from every patient, you're an idiot." So let's not all be James Allison's idiots, okay? So my goal is to learn something from every patient. So this is what we're going to do. Basically, we're going to take the data we have from immunotherapy clinical trials, try to get our mandatory biospecimens that we can then analyze as best we can, accepting the lack of statistical power and really looking at each patient as an individual for response or resistance. We'll then go back to the laboratory with the few immunocompetent mouse models that we do have and start validating some of these mechanisms, looking at combinations that can overcome the resistance. With that data armed, we'll be able to go back and develop new trials with preclinical rationale behind them. And so how are we doing this? So what I'm going to show you here in the next few minutes is the immunoprofiling that we've developed for our study of axitinib pembrolizumab. And this is a multi-parameter profile. So we have flow cytometry data looking at TILs and peripheral blood. One of the benefits to sarcomas is that these tumors tend to be very big and they're often accessible. They tend to be in soft tissue. And so it's no problem for us to get multiple big, juicy core needle biopsies that can then be immediately digested and analyzed for TILs or other immune components. We're doing multiplex immunohistochemistry to look at tissue architecture as well as some of the other immune markers and PD-L1 expression, VEGF functional activity, cytokines. We are using also the nanostring genetic expression panel, looking across the board at multiple immunosignatures, and then also the neutrophil lymphocyte ratio. And so between that trial as well as our future trials, the goal is to use statistical clustering to try to develop multi-parameter signatures that can be applied across histologies and used to sort of target therapies, whether it's VEGF or chemo or monotherapy. And so this is a very busy plot, but I'll walk you through it. So this is just an example of some of the stuff that we've gotten from our analysis of the patients on Axi-Pembro. And so first of all, we looked at PD-L1 expression. And just to orient you, we looked at each of these biomarkers by best overall response, so the likelihood of obtaining partial response or stable disease over progressive disease, progression-free survival greater than or less than 6 months, and then because of the enrichment of ASPS, which we knew was very vascular in etiology, we wanted to also make sure that wasn't confounding. And so again, what we see is PD-L1 expression across the board does not correlate with response, whether it's response or progression-free survival, but it did correlate with ASPS histology. So all of the ASPS patients were PD-L1 positive. TIL infiltration by immunohistochemistry did not correlate. And again, looking more globally by IHC, we did not see trends across any of these outcomes. And so the PD-L1 story is consistent with that data I showed you already. So unfortunately, that is not going to be a good biomarker for sarcomas, it looks like. The neutrophil lymphocyte ratio. So this is a marker that's been shown in other types of cancer to be prognostic and predictive for response to immunotherapy. And so we saw that this was associated in our patient population with response and trended towards progression-free survival as well, was independent of histology. And then finally, of interest to us was VEGF activity. And so you can quantify plasma angiogenic activity by taking patient plasma and incubating it with human endothelial cells in the laboratory and then measuring the resulting proliferation. And so what we saw was that patients with a higher plasma angiogenic activity actually were more likely to achieve a partial response or stable disease, or progression-free survival of greater than 6 months. And what's really interesting is that despite all of those angiogenic factors being targeted by the ASPS fusion, those patients were no more likely to have a higher expression compared to the non-ASPS histologies. So this may turn out to be quite helpful for VEGF therapy. This is also some other work, so again, I'll walk you through it. This is looking more at the flow data. So we looked at TILs as well as peripheral blood mononuclear cells. And what we see here is looking at TILs. We do see a trend, again, small numbers of samples, and so our statistical power is limited, but there is a trend towards improved outcomes with CD3 TIL infiltration and CD8 TIL infiltration. We also see that patients trended towards doing better with a longer progression-free survival if they had a lower CD4 to CD8 ratio within the tumor, as well as somewhat in the peripheral blood, which is what we would expect. More cytotoxic T cells should help with tumor responses. Looking at the TILs further, we looked at checkpoint protein expression in the CD8 compartment, and so we saw a statistical significant association with PFS greater than 6 months with higher PD-1 expression on the CD8 cells. We also noted that patients who did better with a prolonged PFS were more likely to have a higher proportion of central memory CD8 T cells compared to the naive or the less educated subset. And then finally, the last thing I'll show you with this part is in the peripheral blood, in both the CD4 and the CD8 compartment, we saw improved outcomes with TIM3 expressors. So higher TIM3 expression on CD4 and CD8 trended towards benefit. So the other piece of data that I'm going to show you now is looking at the nanostring genetic signature data. So nanostring, if you're not familiar with it, this is the panel we used is the Universal Immuno-Oncology Panel, which has about 700 genes that are arranged or classified into various genetic signatures associated with immune components that you can see listed here. And so this forest plot basically is looking at patients who had progression-free survival of greater than 4 months or less than 4 months. And they're looking for which signatures were upregulated preferentially in the patients that did better and which signatures were upregulated in the patients that did worse. And so better is on the right here in the patients that had a longer progression-free survival, and less progression-free survival is here on the left. The big squares are the ones that represent the statistically significant signatures. And so first of all, I'll show you that the 4 signatures that were associated with better responses included the antigen processing machinery, type 1 interferon signaling and downstream signaling, and then the immunoproteasome, which is a unit that's involved with in the setting of immunologic stress or cell death into creating novel antigens. So these are all innate immunity signatures. Interestingly, we found that B cells and natural killer cells, including the DIM fraction, which is normally associated with the most cytotoxicity, were more highly expressed in patients that did more poorly. And so this is an area that we don't completely understand yet. So let's look at the antigen-presenting machinery, or the innate immunity signatures. So these are just blown up here, and you can see, again, significant differences between poorly progressing patients, so less than 4 months, versus better outcomes. And again, there's a wide variety of histologies represented by all these different colored dots. So there's a range, but a correlation. And if we blow up and look in more detail at the antigen processing machinery immunosignature, just as an example, what we did here is take all of the patients and line them up and normalize their immunoscore for this particular signature across the cohort. And all of the patients, essentially all of the patients who achieved partial response or stable disease were in the upper half of the expression. So high scores tended to have responses, whereas the progressors tended to be lower. And so again, a couple things. So number one, this makes sense, is particularly if innate immunity is really the core problem, which a lot of our data is suggesting. But we also see that histologies are distributed. Not everybody's clustered together. And so this is important when we go on to consider how we're going to analyze these patients and how we assign treatments. This one uterine leiomyosarcoma patient here is an outlier throughout all of the correlative data that we've done, but she progressed at 3 months. And so part of me wants to go back and put her back on study because I'm convinced something went wrong. But, this is the kind of stuff that we need to really pay attention to. All right, so moving on then. So now with some of this data, and again, I'm not showing you everything. There's a ton of data that we're still working through at this point. How can we expedite this in the laboratory and validate and refine our hypotheses, at least for the VEGF story? So we have two murine mouse models that we can use. So these are both immunocompetent. The KP model was developed by David Kirsch, and this is a model of UPS, and it's notoriously cold. So no TILs, resistant to checkpoint inhibitors, no antigens, and they can't even be forced with some of the adoptive protocols. So this is a conditional double mutant with KRAS mutation and p53 deletion that can be induced by adenoviral recombinase. And so in these mice, you will get a sarcoma here in the thigh that can actually metastasize out to the lungs, just like in our human patients. The other model is the relatively famous MCA205 model of fibrosarcoma, which has been used in a lot of immunology work in the laboratory. And so basically, this is a mildly immunogenic, carcinogen-induced model, more inflamed, more TILs, and mildly responsive, at least with tumor growth suppression, to checkpoint inhibitors. And so this is actually a commercially available cell line. And so what we'll do is we'll treat cohorts of each of these mice with axitinib, anti-PD-1, or the combination, and then do the same sort of immunoprofiling analysis that we're doing in the patients. And we'll be able to have at least randomized patients that we can compare the differences in mechanisms. Not patients, mice, randomized mice. There we go. So then chasing the innate immunity question. So what do we do next? So the other study that we're working on, again, this happened at the same time as the Doxo-Pembrose study, but we are combining doxorubicin with dual checkpoint blockade in order to see if we can improve antigen presentation and T-cell expansion that can then be offset by additional inhibition of the checkpoint side. And so this is an open-label single-center phase 2 study that will open here in Colorado next month. There's going to be about 28 patients, again, advanced sarcomas, multiple histologies, with a max of 1 prior therapy. Our primary endpoint is actually the PFS rate at 6 months, not response rate. That is a secondary endpoint, as well as the toxicity profile. And so basically, these patients will get a cycle of priming checkpoint blockade, followed by doxorubicin up to 6 cycles. And then they may receive PD-1 maintenance therapy thereafter. And so all of our patients will also get a tumor biopsy at baseline, cycle 2, day 5, so right after their first dose of chemotherapy, and then at progression is an optional biopsy, and we'll collect blood throughout as well. And so the idea here is that not only are we looking at these patients as whether or not this treatment is going to be effective, but really we want to get a good sense of the correlative analysis here. And so we've again incorporated mandatory biopsies and blood sampling, thanks to the funding from the Cancer League of Colorado as part of this study. And again, we'll take those specimens and do pretty much a similar immunoprofiling scheme as what we did with Axi-Pembro, but we'll also look even in more detail at tumor immunogenicity, so expression of danger receptors and cytokines, as well as genetic expression from these samples. But at the same time, one of those core needle biopsies from those patients at baseline is going to go into an immunocompromised mouse in order to generate a sarcoma PDX, hopefully. We understand that not all of them will take, but the ones that do, we can then select key PDXs that represent the immunoresistant and the immunogenic patients from our trial. We'll have that clinical data in real time as we go. And so for these PDXs that we think are most informative, we can then move forward with the humanized mouse model that's here in Colorado and really delve into recapitulating the clinical trial in those mice. So we can have control, we can have doxorubicin alone, we can have the checkpoints, and then we can explore resistance mechanisms in that way. And although it's not a perfect model, it's, again, representing the patient that we'll actually have correlating human data for as well. We also can use our same syngeneic and transgenic models, and at the end of the day, all these mice will get treated with those combinations, as I mentioned. We'll perform tumor collection and profile these tumors as well in parallel to our human samples. So let's say that we actually do manage to achieve the ability to figure out which patients do better with chemotherapy and which patients do better with VEGF, and we have a multi-parameter immunosignature that's actually feasible. Okay, I get it that that's a stretch, but I think we can do it. How do we validate that moving forward? So there's a couple of things. So we are building that PDX library and the tumor banking protocol so that all patients, not just our trial patients, are having the opportunity to get PDXs growing in our laboratory. These are being profiled as they come in for immune cell components and potentially looking at TIL infiltration and activity. We also have the amazing resources of OBrien and our biorepository staff. And so there's a wealth of additional data, including a fair number of sarcomas that have actually been consented for this protocol, more than you would expect. And so this is another possibility for getting additional clinical data and validation. We have 2 more studies coming down the pipeline in development now, so over the next year or 2. These are multi-institutional IITs or industry-sponsored trials that we'll be participating in, and both are randomized. So this is really where we can get some helpful information from the patient side. Cabozantinib is another VEGF inhibitor, as well as other tyrosine kinases, and so this will be randomized between monotherapy versus the combination with checkpoint inhibitors for soft tissue sarcomas. And then our cutaneous angiosarcoma patient, that super responder I showed you at the beginning, we will be conducting a study of PD-1 versus CTLA-4 PD-1 for these patients, multiple institutions. And so we'll run correlates for both of these studies here in Colorado. And then importantly, so the sarcoma field is very small, and so we're fortunate that we have great relationships with our other co-investigators, and there's only a handful of people interested in immunotherapy in sarcoma in the country, and internationally for that matter. And so one key thing is figuring out how to collaborate. We have to pool our numbers, and so the alliance correlatives will be coming out soon. We don't have Doxo-Pembro correlatives yet. And there's over a dozen ongoing combination studies for sarcomas, and some of those will have correlatives, some of them will not. But if there's a way to encompass all of this data and validate these immunosignatures or our observations, then this is where we're really going to be able to move forward with a paradigm-shifting trial. And so what kind of paradigm-shifting trial are we looking at? So imagine you have a sarcoma patient in your clinic, and you have an immunosignature that hopefully can be done off either archive tumor or peripheral blood. And then you can assign a patient to one of 4 strategies. And again, this is all theorizing here. But let's say you find this sarcoma has either high mutational burden, again, a subset, microsite satellite unstable, which happens every once in a while, or you have somebody with this high PD-L1 expression, lots of immune infiltrates, and you're convinced they just need checkpoint inhibitors. So those patients would then be directed towards mono, dual, or even potentially triple immunotherapy with checkpoints. For most of our patients that have what I theorize is this lack of innate immunogenicity with cold tumors and poor T-cell expansion, or their disease is exploding, which is often a limitation to getting immunotherapy on board because it takes a while, these patients would get moved towards chemotherapy combination. I'm confident that we'll be able to tease out which patients are most likely to respond to VEGF blockade, potentially through these angiogenic pathways and cytokines, as well as plasma angiogenic activity. And so that is another subset of patients that could potentially be directed towards VEGF with checkpoints. And then there's the entire world of adoptive cellular therapy, which I haven't even touched on. But synovial sarcomas and myxoid round cell liposarcomas are known to have NY-ESO-1, MAGE-A4, and there's ongoing industry trials that are focused on harnessing T-cells, engineering T-cells specific for those targets, which are looking quite promising. There's clearly much more work we need to do to identify novel targets on other types of sarcomas, because sarcomas are so dedifferentiated that finding conserved targets is really challenging. But again, I think with more work that we're doing, we'll be set up in order to look at that. And then, as many of you know, obviously I work with Eduardo, and he is leading this really paradigm-shifting autologous TIL protocol with engineering to enhance immunogenicity, tumor immunogenicity and responsiveness of TILs. And so hopefully we'll be able to include sarcomas in this as well. But clearly, lots of work to do, onwards to go. So just to conclude, and some food for thoughts, and then we'll open to questions. So sarcomas can respond to immunotherapy and derive meaningful benefit. And when you see it work once, it's transformative. And so that's what makes you keep coming back and keep trying to see if your patient is that 10 to 20%. The combinations that we looked at with the major resistance mechanisms, again, less than 20%. And so we need to come up with a way to make this better. Innate immunity across all of the studies seems to be a consistent key to failure, at least for a subset of patients. And so figuring out what exact mechanisms are defunct within these tumors in this setting is really critical. I think we need to stop looking at histologies as the stratifiers for trials and for response, because I think we're just going to be limited by the heterogeneity, not only patient behavior, treatment response, genetics, but now immunologic heterogeneity as well. Biomarkers that have proven useful in other cancers aren't so helpful for sarcomas. We can't use TMB, PD-L1 expression isn't very helpful, and TIL infiltration is sort of controversial. We've seen both ways. So we have to go deeper, we have to think smarter and learn more. And again, we're not going to be James Allison's idiots. We're going to learn from every single patient in rare diseases. And this goes across the board. There are other cancers with rare components as well, and we need to take a patient-centric approach for this across the board for immunotherapy. We need to have clinical correlatives and immunocompetent mouse models in order to do this. It has to be a translational approach. And then the last thing I'll leave you with, so fundamentally, sarcomas are cancers of stroma, all right? All those nasty components that you look at in pancreas and lung and all these horrible tumors that we blame the stroma for all things bad with the immune system. I mean, that's sarcoma. So if we can get this to work in sarcomas, I think it's going to have huge implications for how we manage other types of tumors, particularly the most resistant and cold tumors and the ones with huge stromal input. So obviously it takes a village to do this, and I just want to thank everyone, particularly everybody at the University of Colorado who has helped so much in making this transition incredibly smooth and avoiding the downtime, which was probably one of my major fears in making this move. Clearly there's a ton of people at University of Miami that have taken care of me from day one and have made all of this possible as well. And most importantly, my lab has just been an amazing experience. I'm so grateful to everybody in the lab for taking on a clinician and somebody who knows really not that much about immunotherapy or immunology for that matter, and being willing to teach and share their knowledge. Particularly Eduardo, who has changed my life, and Yupanqui, who has also changed my life, and he is my PRA, who is my hands in the lab when I'm stuck in clinic and doing trials. And then I just want to thank all of my funding, and I'm happy to take questions. Thanks. Go ahead.
Are you worried at all about using chemotherapy in combination with checkpoint inhibitors? Because the whole point of a checkpoint inhibitor is to take the brakes off the T cell. Mm-hmm. And what happens then? The T cells proliferate. But they're proliferating in the setting for chemotherapeutics, so they're just going to be dying. Mm-hmm. So is there any thought to maybe stratify those two treatments to allow the T cells to actually expand?
Mm-hmm. Great question. So couple of things. So you're absolutely correct. You will get some T cell death. You'll kill some of them. But actually, most chemotherapies that we use are preferentially myeloid toxic. So like when we treat patients, they will dip their ALC, their lymphocyte counts, but you don't have the nadir like you do with neutrophils. And so while it's not perfect, we think that the process of killing the T cells and then allowing them to rejuvenate or at least recovering after the chemotherapy, you've still planted the seeds for the memory. And part of that is why with the Doxo trial, we're priming first. So even though we know that most of these patients will progress during that cycle, if all the T cells are turned on for that initial hit with the chemo, you're not going to drop. You're not going to kill your immune cells for probably 5 to 7 days after you give the chemo. And so then hopefully the memory cells, the more resistant cells to the treatment will be educated and stick around for recovery. But great question. Yep. Why they're beneficial? It's the other way around. So basically, if you have a high neutrophil to lymphocyte ratio, that's bad. So what that basically means probably is that your lymphocytes, which are your underlying adaptive immunity, is too low, and your myeloid cells are overtaking things. And it's controversial whether it's just a prognostic thing, whether these people are just more immunodepleted, probably after heavy pretreatment, or if it actually is something related to the immunotherapy. Anyone else? Yep.
You have a lot of stuff about the immune signature. The question is, how many of these sarcomas have neoantigens coming out of you? The immune checkpoints work well in folks who had flashes, my cigarettes, sunburn, my virus. This group, I realize it's a subset, but this group kind of stuck with not a lot of healing.
Great question. Yes, They are, many of them are. So the one thing I will say, so the cutaneous angiosarcoma patient, so these are often related in some part to sun exposure. So what's really interesting is we do see a higher mutational burden in angios because of it's more almost like the UV signature in melanoma. So there are subsets of sarcomas, radiation-associated sarcomas, that do have a higher mutational burden. And so for those, there's hope that we can actually play off with the checkpoints, and that will be sufficient. But you're right. For the vast majority, for people that just have, when you do foundation and you find a P53 mutation and that's it, you're kind of stuck. And so that's what we need to figure out is how can we induce neoantigens? I mean, the best way to induce neoantigens is really chemotherapy, radiation, some of these other approaches. And then if the reason they don't have, like, is there a way to reprogram epigenetic therapy or sting agonists or lowering the threshold for antigen recognition? I mean, is there a way to do that? And this is all the stuff that other people are looking at in different types of cancers, but we're just light years behind. So you're absolutely right. It's a huge barrier, but that's really where the majority of our focus needs to be is how do we make these things more immunogenic? Or make all our sarcoma patients smoke, I guess, but that's a little late. So go ahead up in the corner.
Do you observe TLS structures in your biopsies?
Great question. So we actually just ran our Vectra. So we are in the process of analyzing all of that now. There are, so we have, the ones I've seen so far in ASPS, you would not believe the degree of immune infiltration. And so part of it is going to be teasing out if we can see those lymphoid structures, but those tumors are full of immune cells, full of macrophages, and I'll bet you if they're there, it's going to be in those tumors. Anyone else? Thank you all. Have a great rest of your day.